I'll give it just a couple of minutes and then I'll get started.
All righty, perfect.
All right. Dr. McDonald and Samant, you all ready to get started? All right, let's do it. Good morning and welcome to another edition of Grand Rounds for the Department of Medicine at Washington University. I'm John Hickman. It's my pleasure as always to welcome you on behalf of our chair, Dr. Frazier, Drs. Costco, Spencer, and myself. We are just delighted to be joined by two of our fantastic faculty from the Pulmonary and Critical Care Division, Dr. Maanasi Samant and Rachel McDonald. Dr. Samant received her MD for the University of Tennessee Health Science Center before joining us at WashU for internship, residency, and fellowship. We were fortunate enough to have her stay on as faculty, where she continues to work with a pulmonary hypertension practice. Likewise, Dr. McDonald received training both for residency and fellowship here with us after obtaining her MD from the University of Arkansas for medical science. Dr. McDonald currently serves as the Assistant Program Director for Critical Care. So as a reminder, please send any questions you have for our speakers through the Q&A or chat features at the end. If we've got time, I'll help moderate those with our speakers. And with that, please help me welcome Drs. McDonald and Samant for their talk today on the Pulmonary Embolism Response Team, the new face of PE care at WashU. Thank you both so much for joining us.
Thank you for having us.
Yes, thank you. Give me just a moment here to pull up the screen share. Okay, can you all see our slides?
Looks great.
All right, perfect. So thank you, John, for that introduction, and thank you for having us here today. We have no relevant financial disclosures. So the topic of PE management is very wide, and we're not going to have the time to go into specifics on each aspect of PE care. Our goal today is really to talk about the challenging aspects of PE care. We hope to go over kind of the gray areas in PE management and then talk about how pulmonary embolism response teams can be a useful tool to help navigate those gray areas. So what is a pulmonary embolism response team? So it's a multidisciplinary team whose goal is to improve patient care of those who are diagnosed with a PE. The idea is to facilitate rapid assessment and stratification, treatment, and follow-up for patients with PEs. The PERT team was really born out of a lack of consensus agreement, conflicting guideline recommendations, and all in the face of an advent of new therapeutic options that are available for PE. The composition of PERT teams varies from institution to institution, but generally includes an interventionalist service, CT surgery, pulmonary critical care, cardiology, and hematology. The PERT concept was first introduced in 2012, and since then, the PERT consortium has been established, and there are currently 100 institutional members of the PERT consortium. So PERTs are especially useful for patients that have intermediate or high-risk PE, and we'll talk a little bit about what that means a little bit later. Now, that being said, the evidence for PERTs as a whole is limited somewhat by the fact that most of the published literature is single institution analysis. That being said, most of these papers tend to suggest an improvement in care after PERTs are established. Overall, there tend to be lower rates of bleeding, improved 30-day mortality, and a decreased time to therapeutic anticoagulation. So despite this paucity of really robust literature, the European Society of Cardiology, in their most recent iteration of the PE guidelines in 2019, actually added a recommendation endorsing PERT for use in high and certain intermediate risk patients. Now, granted, it is only a level C recommendation, but our goal is to, add to the existing literature and hopefully strengthen that recommendation as time goes on. So our program has been in place since January of 2021, and we wanted to put this slide up here to remind you guys how to activate PERT at our institution. So anyone who meets the listed criteria is a potential candidate for a PERT consult. The consulting service then has to call the transfer center and ask for a PERT consult, after which you'll receive a call through the Microsoft Teams app to join the multidisciplinary discussion. So let's talk a little bit about diagnosis of PE. As you guys all know, the diagnosis, clinical signs and symptoms are very nonspecific. And you really, the key is to have a high index of suspicion for PE as a diagnosis. So, dyspnea isn't always just asthma or deconditioning. If you have a hypotensive patient in the ICU, it doesn't necessarily mean they're septic. Here are some of the major risk factors for VTE and PE. Now, this is not a comprehensive list, but I'm sure you guys have seen or are aware of the known risk factors for PE. So diagnosis, it's really important to not only get diagnostic tests confirming the diagnosis of PE, but also to get lab work, for example, cardiac biomarkers, especially the troponin and proBNP. VQ is a good alternative if a patient cannot obtain a CT scan. We all know that CT angiography is the diagnostic imaging test of choice when it's available. And it's useful because it not only identifies the PE, the location of the PE and the burden of the clot, but it can also provide useful prognostic information. And I know Rachel will touch on this a little bit later too, but it can show signs of right ventricular dysfunction and an enlarged right ventricle. Echoes are another really important part of PE management. So we know that the right ventricle is a low pressure, low resistance system. It's thin walled and it's a compliant ventricle. With increasing right ventricular afterload, the compliant right ventricle then dilates and pushes into the interventricular septum and compresses the left ventricle, which decreases stroke volume and filling of the left ventricle as a whole. These are actually representative echo images from a patient who was a PERT consult last year, and these are the echo images from her time of diagnosis. So this enlargement of the right ventricle pushes into the left ventricle, but it also impedes coronary blood flow to the right side. So you'll get troponin elevations. In addition to that, it stretches the annulus of the tricuspid valve and causes tricuspid valve regurgitation, which is what you see here. Here you see this patient's tricuspid valve regurgitating jet. Sometimes when we're looking at echoes of these patients, it can be kind of challenging to tease out, is this an acute elevation in PA systolic pressure, or is this more of a chronic process? Generally speaking, if you're seeing evidence of an RA systolic pressure, or sorry, an RV systolic pressure or PA systolic pressure over 50 to 60 millimeters mercury, you should really be thinking, does this patient have chronic pulmonary hypertension? Here's a really nice graphic from the ESC guidelines that depicts all the different ways right ventricular dysfunction can manifest in acute PE. You can get dilation of the right ventricle, you can get a dilated IVC, you'll have evidence of elevated PA pressures, potentially even see a mobile thrombus on the right side, and then you can also get an assessment of how well the right ventricle is functioning. So what is the purpose of all of these things? The lab work, the echocardiograms, it's really so we can appropriately risk stratify patients. And risk stratification helps us identify those patients that are going to be at increased risk for adverse outcomes. I think many of us have seen this figure from the ESC 2019 guidelines, but it depicts the right RV spiral of death. This occurs when patients have an acute PE that occludes up to 30 to 50% of the pulmonary vascular bed. While overall long-term mortality continues to decrease, short-term mortality is still not insignificant. So our goal as clinicians when we're treating these patients is to identify patients before they fall too far down the spiral. So how do we do that? How do we appropriately risk stratify patients? To help try to answer this problem, there are a lot of scoring systems out there to try and risk stratify patients. One of the easiest ones that you can do is the simplified pulmonary embolism severity index. The one caveat to this is that it's more helpful to identify patients at low risk for decompensation and not quite as helpful with patients who are at higher risk. As you can see, if you meet any of these criteria, you essentially fall into the high risk category. The SPECI scoring system then helps us understand the ESC guidelines that help risk stratify patients into low, intermediate, and high risk. There's really no debate as to what constitutes a low or high risk patient. It's this intermediate group that is challenging to classify. So the ESC guidelines subdivided the intermediate group into intermediate low and intermediate high. Intermediate high patients are those patients that have elevated cardiac biomarkers and evidence of right ventricular dysfunction. So and what's challenging is that classifying a patient as having right ventricular dysfunction can sometimes be subjective because those assessments are made off of echo and or CT parameters. But we as a PERT group are really very interested in this group, in the intermediate high risk group, because we know that they have increased risk of going into the high risk category. We still don't really have a great tool to identify which patients from intermediate high are going to go into high risk. We know that those patients have increased in hospital mortality. And generally speaking, we usually advise those patients to be monitored closely, usually in an ICU setting, and potentially can be considered for advanced therapies as well. So I put this table up here to really just emphasize that there are lots of scoring systems out there. There's lots of blood works and lab work that you can get to try to risk stratify these patients, but no one scoring system or lab in isolation is able to appropriately risk stratify these patients. Really, you should be thinking about all of these things together and looking at these patients not at just one snapshot in time, but over time. As we know, patients' clinical situations can change. I think risk stratification is truly one of the most difficult aspects of PE care. Even though the ESC guidelines define what an intermediate high-risk patient is, we still don't really have a clear understanding of why certain intermediate high-risk patients do okay and other ones do not. So there's a lot of work currently being done to help tease out which patients in that intermediate group are really going to decompensate. So to help kind of answer that question, this group out of Boston published this paper last year that took the idea of hypoperfusion during a PE event to see if it had any impact on PE-related outcomes. So they used computer software to try and analyze they choose computer software to analyze distal vessel volume in patients with PE. Here you have a representative CT scan showing the area of hypoperfusion in the PE. Panel B shows the area of poor arterial perfusion, and panel D shows poor distal venous perfusion in patients with PE, and panel C is a normal lung. And what they found was that patients that had limited or had less distal venous perfusion were actually at increased risk of increased 30-day and 90-day mortality, even after adjusting for all of these covariates. And here's the Kaplan-Meier curve showing that patients that have less distal venous volume are more likely or are at increased risk of mortality. So, if there's a way that we can incorporate these advanced imaging techniques in real time, that could be another potential tool to help risk stratify your patients. So, and multiple people have also been looking at various echo parameters to see if they could be useful to risk stratify patients as well. This group out of NYU looked at their institution's PERT activations to see Well, does left ventricular stroke volume have an impact on overall mortality in PE? And is this another tool that we can use in real time to risk stratify people? They looked at a composite outcome of in-hospital death or cardiac arrest and shock or need for reperfusion therapy. And they found that a reduced left ventricular VTI had an increased rate of both clinical outcomes. So kind of piggybacking off of that idea, this group out of Cleveland published this paper last year to try and see whether a quick assessment of your PA systolic pressure and your left ventricular stroke volume taken together, could that be predictive of poor outcomes as well? We know in PE, there's an acute elevation in PA systolic pressure from the occlusion of the pulmonary arteries, as well as hypoxemic vasoconstriction. And as that last study showed us, left ventricular stroke volume is an indicator of poor PE outcomes. So they used a PA systolic pressure to left ventricular systolic stroke volume ratio greater than 1 to see if that was associated with worse outcomes. And they did find that it was associated with worse outcomes. And they actually then compared the performance of this ratio to other clinically available risk stratification tools, namely the PESI and the BOVA, and they found that using this ratio actually performed better than the PESI and BOVA scores. So again, if you have access to good echocardiographic measurements in real time, this could be another potential tool to help prognosticate outcomes in your patients. So, we do our best to try and risk stratify patients in real time and see, can we put them in a certain risk category and then tailor a treatment appropriately. So this group actually aimed to answer the question, well, if we do that, does that change outcomes? If we use an upfront prognostic pathway, does that change our outcomes? So this group used this this management pathway that was derived partially from the ESC 2019 guidelines to see if it ultimately changed outcomes. And what they found was that while mortality was not different in patients who got the upfront prognostic pathway, their length of hospital stay was lower, and actually the cost of prognostic tests used was also lower. So I'm going to give this to Rachel here, and she's going to talk to you a little bit about treatment of acute PE.
All right, thanks, Maanasi. And thanks everybody for coming to listen to us talk a little bit to you guys about PE management today. So as Maanasi said, I'm going to focus my portion of this talk on management strategies of acute PE. And when thinking about treatment of acute PE, treatment options are broadly divided into 3 lanes of care: 1, restoring hemodynamics; 2, reperfusion; and 3, prevention. So for low-risk PE patients, the standard of care is treatment with anticoagulation. And for high-risk PE patients, the standard of care has been systemic thrombolytics. The real dilemma, as Maanasi was alluding to, is regarding appropriate treatment for patients with intermediate risk PEs and deciding between anticoagulation strategies and reperfusion strategies. So when evaluating patients with intermediate risk PE, additional factors such as syncope or elevated lactate, or subtle changes in hemodynamics such as increasing heart rate, downtrending blood pressure, these all may alter our risk-benefit assessment in favor of reperfusion strategies before the development of frank hemodynamic instability. So if treatment with anticoagulation is chosen up front, close monitoring is recommended in these cases to allow for the early detection of hemodynamic decompensation and the need for rescue reperfusion therapy. When deciding which treatment option is best for intermediate risk patients, it can be very difficult, and it's often made on a case-by-case basis. So I'm going to focus the majority of my portion of this talk on the management of patients with intermediate risk PE. So before discussing treatment options, I just wanted to present a case to you all of a representative patient that was evaluated by the PERT team. This is patient JW. She's a 42-year-old female with a history of PE in 2016, was previously on Eliquis for anticoagulation, but not currently. Also had a history of second trimester fetal demise that was presumed secondary to a trisomy, who presented to the ED with dyspnea and syncope. As part of her workup, she got a CTPA, and you guys can see representative slices here of her PE study. She did have bilateral PEs noted with an RV to LV ratio of 1.27. Her lab work had a troponin of 0.08, a proBNP of 9236, and on physical exam, she was hypertensive, was mildly tachycardic, was initially hypoxemic on room air, but improved to normal oxygen measurements on just low supplemental oxygen. And otherwise on physical exam, she was comfortable appearing and just mildly tachypnic. So the PERT team was consulted as she was classified as an intermediate risk PE, and there was question if she would benefit from reperfusion therapy. So as mentioned, the main decision point when evaluating intermediate risk PE patients is the decision between treatment with anticoagulation or treatment with reperfusion strategies. So regardless of whether or not reperfusion is performed, all patients with acute PE should be started on anticoagulation as soon as possible after making the diagnosis, as we know that time to therapeutic anticoagulation affects mortality. So this is evidenced here in this article from CHEST in 2010. This found a difference in both inpatient and 30-day mortality between patients whose PTT was therapeutic on a heparin infusion within 24 hours compared to those who were not therapeutic during that time frame. Additionally, when choosing anticoagulation strategies, which anticoagulant is superior for upfront treatment of PE is unclear. Here at BJH, the most commonly used agent for anticoagulation is unfractionated heparin. Again, when starting a patient on unfractionated heparin, time to therapeutic anticoagulation is critical for patient outcomes. So this study done at MGH included patients that were evaluated by a PERT consult team and treated with unfractionated heparin. About 50% of these patients fell into the intermediate risk PE category. What this study found was that over the first 48 hours during any 6-hour time interval, somewhere between 14 to 35% of patients had a therapeutic PTT. Of those that were not therapeutic, about 50 to 60% were subtherapeutic and about 10 to 35% were supratherapeutic. Furthermore, 36% of patients had both subtherapeutic and supratherapeutic values during that first 48 hours, just demonstrating how difficult it is to achieve reliable anticoagulation with heparin infusions. So what's most striking is that at 48 hours, only 60% of these patients had achieved even one therapeutic PTT, and 50% of patients took 36 hours to achieve their first therapeutic PTT. So given the difficulty with achieving appropriate anticoagulation with unfractionated heparin, the trend in PE treatment in recent years has really shifted to favor low molecular weight heparin for anticoagulation as opposed to unfractionated heparin. This shift in practice patterns is based on several advantages for low molecular weight heparin, most notably that low molecular weight heparin has much more reliable pharmacokinetics, which obviate the need for routine lab monitoring and guarantees therapeutic anticoagulation quickly. Also, because there's no need for dose adjustments, low molecular weight heparin is easier to administer. It is less likely to be associated with medication errors as well. And the main disadvantages of low molecular weight heparin are its need for avoidance and renal failure. It's difficult to dose in morbidly obese patients, and it's incompletely reversible. So even though practice patterns are changing to prefer low molecular weight heparin over unfractionated heparin, there's really limited data regarding the outcomes comparing treatment of patients with these two anticoagulation strategies. This Cochrane review here included 29 RCTs with over 10,000 patients with venous thromboembolism. Compared to unfractionated heparin, the pooling of these trials showed that treatment with low molecular weight heparin actually resulted in fewer recurrent blood clots, fewer cases of bleeding, and a reduction in clot burden. However, when pooling the data from the 7 studies in this analysis of patients with intermediate risk PE, the results are somewhat different. When comparing unfractionated heparin to low molecular weight heparin in intermediate risk PE patients, there was no significant difference in recurrent VTE, change in thrombus size, incidence of major bleeding, or mortality. So overall, while there appears to be some advantages to low molecular weight heparin, the data is really still not clear that treatment with low molecular weight heparin is superior to treatment with unfractionated heparin. So let's move on and discuss some reperfusion strategies. The best studied reperfusion strategy in acute PE is systemic thrombolysis. As mentioned, this is the standard of care for patients with high risk or hemodynamically unstable PEs. However, given the high mortality of patients with intermediate risk PE, and particularly those of intermediate high risk PE, there's been interest for several years in using reperfusion strategies in these patients to attempt to improve outcomes. So the 3 best known trials that have investigated the use of systemic thrombolytics in patients with intermediate risk PE are the Top-Coat trial, the PATHOS trial, and the Moppet trial. And I'm sure you all are probably familiar with these trials, so I will just briefly mention them here. But overall, none of these trials have shown that upfront thrombolytic therapy improves mortality in patients with intermediate risk PE. They do, however, support the idea that upfront thrombolytic therapy may prevent patients with intermediate risk PEs from decompensating and may decrease the development of pulmonary hypertension and improve patient quality of life metrics. However, these benefits have been offset by an increased risk of bleeding with thrombolytic therapy compared to anticoagulation alone, with about a 10% risk of major bleeding and about 2% risk of intracranial hemorrhage with thrombolytics. So this table comes from a meta-analysis published in JAMA in 2014. It's looking at the use of systemic thrombolytics in PE versus anticoagulation alone in both intermediate and high-risk PE patients. You can see here that there was an overall mortality benefit for lytic therapy with a mortality of 2.17% with lytic therapy versus a mortality of 3.89% with anticoagulation. Again, this comes with an increased risk of major bleeding and intracranial hemorrhage. When looking at the subset of patients over 65 years old, there was actually no significant difference in mortality, but there was an increased risk of major bleeding, really favoring anticoagulation in this subset of patients. When looking at subset of patients that were less than 65 years old, there was a much lower risk of major bleeding, but there was actually no significant mortality difference in these patients. Furthermore, when looking at just patients with intermediate risk PE, there was an overall mortality benefit with lytics, but again, at an increased risk of major bleeding. So given the potential improvement in outcomes with systemic thrombolytics in certain patient populations, interest has really emerged to discover new treatment modalities aimed at pulmonary artery reperfusion while mitigating the risk of major bleeding that's been found to come along with systemic thrombolytics. So out of this interest, several catheter-based therapies have been created for the treatment of acute PE over the past several years. To start with, there are two types of catheter-based therapies available: catheter-directed thrombolysis, which is seen here, and aspiration thrombectomy. So catheter-directed thrombolysis delivers fibrinolytic drug through multi-side hole catheter that's placed directly into the pulmonary artery and directly into the thrombus under imaging guidance. The theoretical benefit of these catheters is to allow for administration of a lower dose of TPA than is administered systemically, while at the same time benefiting from thrombus dissolution and pulmonary artery reperfusion. The picture on the left is a simple infusion catheter. It's placed into the pulmonary vasculature and infuses TPA through multiple side ports. The picture on the right here is an ultrasound assisted catheter. This is a variation on the simple infusion catheter as it combines ultrasound technology with thrombolytic infusion. Ultrasound technology was added to infusion catheters based on data that showed that high frequency, low power ultrasound has been shown in animal models to separate fibrin strands and increase thrombus surface area, thus increasing TPA receptor sites. So the idea behind ultrasound is that it will theoretically allow for equivalent or better clot removal because of higher drug concentration within the clot, but additionally, that theoretically could allow for a much lower dose of fibrinolytic drug and thus potentially less bleeding. So as an alternative to catheter-directed thrombolysis, catheter-based aspiration thrombectomy is another treatment option that exists for the treatment of acute PE. On the left is the Indigo aspiration catheter from Penumbra, and on the right is the FlowTriever device from Maanasi. The Indigo aspiration catheter is a simple aspiration catheter that's advanced using imaging guidance into the pulmonary artery, just proximal to the thrombus, followed by clot aspiration. The FlowTriever catheter combines an aspiration catheter with the FlowTriever device, which contains some self-expanding metal discs that are deployed across the thrombus and then retracted into the aspiration catheter to mechanically remove thrombus from the pulmonary artery. Of note, the Indigo catheter is a smaller bore catheter compared to the FlowTriever device, with the idea the smaller catheter has a lower risk of causing device-related complications and could potentially reach clot located more distally in the pulmonary vasculature. However, there's debate as to whether the Indigo catheter is as effective at removing clot as the FlowTriever device. However, differences in clot extraction and complication rates between these catheters is really still to be determined, as there are no trials comparing these devices head to head. So the first step in evaluating these catheters as potential treatment modalities for acute PE was first to prove that catheter-directed therapies are effective. Before talking about specific studies, I just wanted to take a moment here to discuss RV to LV ratio in acute PE, as it's used throughout the literature and discussed on virtually every PERT consult. When deciding how to determine effectiveness of catheter-based treatments, initial focus has been on changes in RV to LV ratio. This emerged as a surrogate endpoint for RV dysfunction, partly because RV to LV ratio has been linked to outcomes from acute PE, but also because it's information that's available at the time of PE diagnosis and is more easily measured and readily available than echocardiography. While there's some data that RV enlargement on chest CT has been linked to short-term PE outcomes, data regarding this is really conflicting. Just as a couple of examples, I've included here two studies with differing results. The study on the left is from Circulation in 2004. It showed that in patients with acute PE, early RV enlargement on reconstructed CT at the time of diagnosis predicted 30-day mortality, and that mortality actually increased as the RV to LV ratio increased. Additionally, the RV to LV ratio predicted early complications of acute PE, such as need for CPR, mechanical ventilation, vasopressors, or the need for reperfusion therapies. So this is in contrast to the PROTECT study shown on the right here from 2014, which did not find RV dilation on CT at the time of PE diagnosis to predict 30-day mortality or the development of life-threatening adverse events. Of note, the study did find that RV dilation on echo, elevated BNP, and elevated troponin all were associated with increased risk of adverse events in patients with acute PE. So given that the data from individual studies is conflicting, I included this meta-analysis here from 2013 of normotensive patients with acute PE. The study did find that overall patients with RV dilation on CT had a 1.8-fold increased risk of short-term death compared with patients without RV dilation on CT. So acutely decreasing the RV-LV ratio has been extrapolated from this as a measure of efficacy for PE treatments, although acutely decreasing RV-LV ratio has not been shown to directly impact outcomes in acute PE. However, based on the fact that RV dilation seems to correlate with PE-related death, RV to LV ratio and RV diameter have become a tool that we use to risk stratify patients with acute PE. Of note, RV dilation alone really should not be used to make decisions regarding treatment, but it's rather one diagnostic tool for evaluating clinical severity of acute PE and a potential for risk of decompensation or adverse events. So here's a table summarizing the major studies of efficacy for catheter-based therapies. As you can see, all these studies were conducted mostly in patients with intermediate risk PE. The Seattle 2 trial is the largest prospective study to date for catheter-based therapies and found that ultrasound-assisted thrombolysis was effective at reducing RV to LV ratio and PA pressure 48 hours. Similar efficacy results were found in the other 3 studies evaluating aspiration thrombectomy devices as well. So of note, you can see there's an increase in major bleeding in ultrasound-assisted thrombolysis of about 10% compared to the studies of aspiration thrombectomy, which have shown a major bleeding rate of about 1%. This difference in major bleeding isn't really surprising as the aspiration thrombectomy trials had a low rate of use of rescue thrombolytics. Additionally, there's a low rate of clinical deterioration or device-related complications in the aspiration thrombectomy studies, supporting the idea that these procedures are fairly safe to do. On the bottom here, the FLASH study has some longer term follow-up than 48 hours and has released a 30-day data, which looks at more patient-centered outcomes of quality of life and dyspnea scores, as well as some imaging findings of RV function, and found all of these to be significantly improved at 30 days. Unfortunately, all these studies are single-arm studies without a control comparator group, namely an anticoagulation control group. So therefore, we can't really say from this data that these treatments provide better patient outcomes than the current standard of care, which is anticoagulation. So what do we know about catheter-based treatments compared with anticoagulation? This is the ULTIMA trial. It was a randomized controlled trial examining the use of catheter-based thrombolysis, specifically an ultrasound-assisted device for treatment of intermediate risk PE patients compared with heparin alone. It was done in Germany and Switzerland and enrolled 59 patients with intermediate risk PE. Patients were randomized to ultrasound-assisted thrombolysis versus anticoagulation with heparin. The patients in the catheter group were given somewhere between 10 and 20 milligrams of TPA over 15 hours. So this trial did show that ultrasound-assisted CDT was superior to anticoagulation alone in reversing RV dilation at 24 hours with really no increase in bleeding complications. What's particularly interesting about this, though, is that while there were differences in reversal of RV dilation at 24 hours between the groups, this difference did not persist at 90 days. So what this seems to suggest is that while ultrasound-facilitated catheter-directed thrombolysis accelerates the short-term recovery of RV function, a catch-up phenomenon may occur in those patients that are treated with just anticoagulation alone. Nevertheless, the ULTIMA trial was the first RCT to test a catheter intervention in patients with acute submassive PEs and actually led to FDA approval of ultrasound-assisted thrombolysis for the treatment of PE. So this is a retrospective observational study that was performed at the University of Pittsburgh. It included 339 patients with intermediate risk PE that were admitted to the ICU. 240 of them received anticoagulation and 99 received CDT. And overall, the study did find that mortality was lower in patients that received CDT versus those that received anticoagulation, with a 30-day mortality of 3% in the CDT group and 6.1% in the anticoagulation group. Additionally, one-year mortality in the CDT group was lower at 8.1% versus 18.2% in the anticoagulation group. So other differences that were observed between the two groups were that patients in the CDT group had a shorter length of stay and actually had a decreased rate of need for transfusion when compared to the anticoagulation group. So you can see we're in need of some more high quality data regarding the performance of these catheter-based therapies versus anticoagulation to determine if catheter-based therapies are really providing better outcomes for patients with acute PE. Fortunately, there are a couple of ongoing trials designed to help answer this question. The HI-PATHO trial is looking at patients with intermediate high-risk PE and comparing treatment with ultrasound-assisted thrombolysis versus treatment with anticoagulation alone in regards to a 7-day composite outcome of mortality, decompensation, and PE recurrence. To be included in this trial, patients not only have to meet the criteria for intermediate high-risk PE, but they have to have a presumed elevated risk of early death or hemodynamic collapse based on vital sign abnormalities. So if this trial is positive, it could help us identify a subset of patients that benefit from catheter-directed thrombolysis as opposed to treatment with just anticoagulation alone. The PE track study is another study that's hopefully coming out in the near future. It's also comparing CDT to anticoagulation, but is enrolling a slightly less severe cohort of PE patients. The main benefit of this trial is that it's designed to evaluate the impact of these treatments on long-term patient-centered outcomes of acute PE, an area which we really don't know a lot about currently. So given that a large driver in the emergence of these therapies is to minimize the exposure of patients to thrombolytics, what dose of thrombolytics is the optimal dose? So this is the Optilized PE trial. It's a multi-center RCT designed to answer that question. It was conducted in the USA and Europe and enrolled 101 patients with intermediate risk PE. Patients were randomized into 4 arms with different dosing and infusion duration strategies using an ultrasound-assisted catheter. So doses of TPA infused ranged from 4 milligrams to 24 milligrams. Infusion durations range from 2 hours to 6 hours. Of note, arm 4, which was the arm with the highest dose of thrombolytics, was closed early after it was noted to have increased bleeding rate compared to the other arms. So when comparing these 4 different treatment strategies, the RV to LV ratio improved in each of the 4 arms by approximately 25%. Quantified clot burden seen on CT also statistically improved from baseline in each arm. However, you can see that as the TPA dose and infusion duration increased, residual clot burden decreased without associated similar dose-dependent changes in RV dilation, which would suggest that clot burden and RV dilation don't directly correlate to each other. So overall, the study had a 4% risk of major bleeding. There was 1 CDT-related intracranial hemorrhage and a 1% 30-day mortality. So while the rate of major bleeding was lower than that seen in Seattle 2 trial or with systemic thrombolytics, the risk of bleeding in ICH is still higher than what we see with anticoagulation alone, even with these very low doses of TPA. So in addition to short-term results, there's now some 1-year data from Optilized PE that focused on the measurements of right heart dysfunction and patient-centered outcomes. So in addition to changes in RV to LV ratio, these outcomes include improvements in echo parameters of RV function and pulmonary hypertension, as well as improvement in patient functional status as evidenced by improvement in 6-minute walks and patient-reported physical function via the PROMIS PF scores. They also noted an improvement in quality of life in PE-related quality of life scores. So even though the study found long-term improvement in echocardiographic findings of RV dysfunction, improvement in functional outcomes, and improvement in quality of life for patients treated with very low doses of thrombolytics, there's still no control arm in the study to compare how these patients would have done with anticoagulation alone. The Knockout PE registry has enrolled both retrospective and prospective cohorts of patients with intermediate high-risk PE across the US and Europe. This study was designed to look at examine practice patterns in regards to the use of CDT, as well as to look at some 1-year follow-up of patients that were treated with ultrasound-assisted thrombolysis. So this study left the decisions regarding thrombolytic infusion, dose, and duration up to the discretion of each site investigator and found that practice patterns have changed after the release of the Optilized data. CDT protocols that are currently being used are treating patients with lower doses of lytics and over shorter durations, with about 1/3 of patients in the study receiving less than 12 milligrams of TPA. So similar to Optilized, the study found that even with low doses of TPA infusion, there were still similar decreases in RV to LV ratio as found with longer infusion durations and higher doses of TPA. Additionally, there's been some preliminary 3-month data released from this study, and it found 41% improvement in quality of life from baseline. Again, unfortunately, there's no control arm to compare this to, so we don't really know how this compares to patients that are treated with anticoagulation alone. The big question regarding catheter-directed thrombolysis is whether the addition of ultrasound technology actually leads to improved clot resolution and improved patient outcomes. So what do we know about how ultrasound-assisted catheters compare to simple infusion catheters? This is the PERFECT study. It's a multi-center PE registry that enrolled 101 patients with both submassive and massive PE. 64% of them were treated with simple infusion catheters and 36 were treated with ultrasound-assisted catheters. Overall, the study didn't find found that CDT improved clinical outcomes of RV strain and PA improvements in PA pressures, but it didn't find any advantage in those treated with ultrasound-assisted catheters versus those treated with just simple infusion catheters. The Sunset PE is a multi-center randomized clinical trial. It enrolled 82 patients with intermediate risk PE, 93% of which were actually intermediate high risk. Patients were randomized 1-to-1 to ultrasound-assisted lysis versus simple infusion catheters. While this trial did find that both ultrasound-assisted and simple infusion catheters decreased clot burden, it didn't find any difference in decrease in clot burden between the two groups. Furthermore, there was actually a greater reduction in RV to LV ratio in the simple infusion catheter group compared to the ultrasound-assisted group. So this trial did use higher doses of TPA than was used in the low dose TPA study, with average lytic doses of 19 milligrams in the ultrasound assisted arm and 18 milligrams in the simple infusion arm. So perhaps the use of ultrasound assistance could allow for lower doses of TPA administration with similar outcomes to those seen here. And this is just another area where we're currently lacking data. A post hoc analysis was performed of this trial, including 20 patients that received less than 8 hours of lysis. This did show an increased improvement in clot burden with ultrasound-assisted catheters compared to simple infusion catheters, but didn't show any difference in RV to LV ratio between the two groups. So overall, ultrasound-assisted catheters may have some benefit, but the benefit likely doesn't outweigh the cost of the catheters, as these ultrasound-assisted catheters are 10 times more expensive than simple infusion catheters. So we've talked a lot so far about catheter-directed thrombolysis. What do we know about aspiration thrombectomy and how it performs compared to catheter-directed thrombolysis? So unfortunately, there are no trials comparing aspiration thrombectomy with CDT. However, the Peerless study is an RCT that will hopefully provide us with some information regarding the comparative effectiveness of these catheters. So this is an RCT comparing the Inari flow retriever device with a simple infusion catheter, and we'll compare the two in terms of the composite endpoint listed here. So what happened with our patient JW? The first step in deciding appropriate treatment for her was to risk stratify her. Given the fact that she was hemodynamically stable but had imaging findings of right heart strain and positive biomarkers, she was classified as an intermediate high-risk PE patient. Additionally, her SPECI score at presentation was 1, giving her about a 9% predicted 30-day mortality. So there are a couple of things about her presentation that made her seem at higher risk for decompensation. One was her presentation with syncope, and the other was the fact that she continued to have increasing oxygen requirements despite receiving anticoagulation. So ultimately, the decision was made to proceed with aspiration thrombectomy. Here are some representative angiograms pre and post aspiration, as well as pictures of the clot that was removed from her pulmonary arteries. So she tolerated the procedure very well and was able to be discharged home a few days later with anticoagulation for chronic treatment. So overall, CDT has been shown to reduce RV to LV ratio and PA pressures acutely, and there's some data that these treatments may improve quality of life and exercise tolerance in the long run. However, there's really limited data to determine if CDT provides better outcomes than either standard anticoagulation or systemic thrombolytics. These interventions do seem fairly safe, as there have been really reported low rates of adverse events in the published data so far. Overall, catheter-based interventions are appropriate for use in patients with high-risk PE who have contraindications to systemic lytics and can be considered on a case-by-case basis for patients with intermediate risk PE. So what's missing? So far, studies have used improvement in RV to LV ratio as the main endpoint for measuring treatment success. And while this was a good surrogate endpoint for preliminary trials, what's really lacking is data comparing catheter-based therapies against standard of care in regards to their effect on both short-term and long-term patient-centered outcomes. So short-term outcomes such as clinical deterioration and mortality, and longer-term outcomes in terms of long-term mortality, quality of life, exercise tolerance, and functional capacity. And with that, I will turn things back over to Dr. Samant.
All right, so now let's talk a little bit about what to do with your patient after they've been treated acutely for their PE. There's really not a lot of guidance telling us what to do in especially the intermediate risk population about when is it safe to transition your patient from low molecular weight heparin or heparin drip to an oral anticoagulant. And the PITHO2 investigators attempted to answer this question. So this was a single-arm prospective trial that looked at, that assessed the safety and efficacy of switching patients from parenteral anticoagulation to a DOAC at the 72-hour mark. Investigators looked at certain parameters like lab work, vital signs, clinical signs and symptoms, and then assess to see if they were safe to transition to a DOAC. The investigators used a bigotran in this trial. What they found was that at the 6-month mark, rates of recurrent VTE were low. They were only 3%. Additionally, bleeding rates were also low, and the median length of stay was 6 days when patients were treated this way. So this suggests, and while there hasn't been no head-to-head comparison to usual care, this suggests that early transition to a DOAC can potentially reduce hospital stay and is certainly effective in treatment of intermediate risk PE. So what happens to patients after they're discharged from the hospital? As some of you guys might know, Dr. Kristen Sanfilippo in the Division of Hematology and I have started a PE clinic where we evaluate these patients after discharge at anywhere from 1 to 3 months post-discharge. And this is just a sample set of guidelines that we sometimes refer to when we're evaluating these patients. After we see them in PE clinic, we'll follow up with them in pulmonary clinic and or hematology clinic as needed. And, this is really just a sample because there's no set algorithm for how to manage these patients after they leave the hospital. The reason for that is that we still don't totally understand the natural history of the disease. So what happens after a patient has a PE? Multiple studies have reported varying rates of functional impairments after PE. The reported incidence is anywhere from 30% to upwards to 50 to 60%. One of the best studies that I think tried to answer the question of what really happens to patients after PE was the ELOPE study. This was done in Canada in 5 centers, published in Chest in 2017. And they tried to identify the incidence of exercise limitation in patients who had survivors of PE. The way they defined exercise limitation was an inability to achieve a VO2 max of at least 80%. And what was really unique is that the investigators did cardiopulmonary exercise testing, echoes, CTs at various time points up until a year out from discharge from the hospital. What they found was that actually close to 50% of patients met the primary outcome and that they were unable to achieve efficient exercise at the 1-year mark. The patients that were more likely to do that were women, have higher BMI, and had higher PA diameter on initial CT and higher PA pressures on their 10-day echo. The investigators also looked at, well, does the degree of occlusion of the PA at time of diagnosis impact frequency of exercise limitation? And they found that the degree of occlusion did not impact frequency of exercise limitation. Interestingly, patients that had the 1 month at the 1 month mark, patients that were unable to achieve efficient exercise at the 1 month mark were also more likely to still have that same problem at the 1-year mark. 46% had persistent clot at 6 months and 41% had persistent clot at 1 year. So what does all of this mean? When we looked at that group of patients in the ELOPE study that was unable to achieve efficient exercise, when we looked at what truly limited those patients from achieving efficient exercise, it was more so an inability to achieve peak heart rate and less so a pulmonary vascular problem, which suggests that there's a fair amount of deconditioning that occurs with this patient population after discharge. And especially if we look at the 1 month CPET mark and that patients that couldn't achieve efficient exercise at 1 month were more likely to still have that same problem a year out, is there some role for early intervention in this group to try and get these patients into a monitored exercise program or potentially even into pulmonary rehab? If we get these patients active and exercising early, could we potentially then reduce the burden of symptomatic limitation after index PE? Some older and more recent cohort studies have also suggested that muscle deconditioning, especially in the presence of excess body weight and cardiopulmonary comorbidities, was also responsible for some of the dyspnea that was reported after index PE. So this study it was a little bit different from the ELOPE trial. It was published in Chest in 2020, and this looked at an enriched group of patients in that these investigators looked at patients only that had reported symptoms of dyspnea after their index PE. The ELOPE trial looked at all comers after index PE. And what they found was that, patients who were truly short of breath, they may or may not achieve peak exercise, but a fair portion of them had true limitations in pulmonary vascular physiology and or cardiac physiology. Upwards of 2/3 of patients had issues with increased dead space ventilation at peak exercise or had reduced stroke volume, and 1/4 of them had both. So, I wanted to bring this study up here because, if we just look at the ELOPE trial, it's easy to kind of assume that all patients who've had a PE, most of them are going to be deconditioned, but really we should be looking closely at those cardiopulmonary exercise testing and appropriately evaluating patients for presence of clonic clot or pulmonary vascular disease or cardiac dysfunction, and not just assuming that patients have deconditioning after their PE. So this brings me to the concept of post-PE syndrome. So there's some debate as to what actually constitutes this entity, but essentially it includes patients with persistent thrombi, patients with measurable limitations in cardiac or pulmonary function, and reported symptoms of reduced quality of life. We know that incomplete thrombus resolution occurs in about 1/4 of patients after PE. And then anywhere from 10 to 30% can have evidence of persistently elevated PI pressure or some RV dysfunction on their echo. And then CTEPH, which I'll touch on just briefly later, CTEPH is an often reported and frequently and very feared complication of post-PE syndrome, though the incidence is much lower. So is there anything that we can do in the acute setting to help prevent post-PE syndrome? Rachel kind of talked about this a little bit already, but the Coat trial, which was one of the systemic lysis trials, showed that patients that received lytics were less likely to report decreased quality of life at the 3-month mark. The Moppet trial, also, which was the half-dose lytic trial, showed that patients that received systemic lysis were less likely to have elevated PA pressure or RV dysfunction at the 2 to 3 year mark. Now, this is contradicted by the long-term data from PITHO. PITHO was, one of the largest trials looking at systemic lysis in the intermediate risk group. And what they found was that at the 1 year mark, patients that received lytics, there was no difference in rates of mortality, dyspnea, or RV dysfunction at the 1 year mark. That being said, the PITHO investigators also looked at a cohort of all patients, regardless of whether or not they received lytics, and then tried to define the frequency of post-PE syndrome and CTEPH. So they looked at a composite outcome of post-PE syndrome and CTEPH and tried to identify potential predictors of developing that entity. And one of the factors that they found was that if there's incomplete or absent recovery of echo parameters at the 6-month mark, those patients were more likely to develop post-PE syndrome and or CTEPH. So does thrombolysis help? Its data is conflicting. We do know that anticoagulation alone does not protect against post-PE syndrome. As Rachel mentioned, thrombectomy has yet to be studied, and we also haven't really looked very closely at time to intervention. I wanted to just briefly talk about chronic thromboembolic disease. Essentially, this is a disease process where there are persistent thrombi, and while there's no pulmonary hypertension at rest when you cath these patients, there is evidence of pulmonary hypertension at end exertion manifested by pulmonary vascular disease or increased dead space ventilation. This is a particularly challenging disease process to manage because CTEPH treatment guidelines don't really apply to this patient group. And then I'm not going to talk too much about CTEPH because that's a whole nother talk in itself, but I just wanted to mention this because this is a very frequently cited, very feared complication of CTEPH, but of acute PE, but the actual incidence of it is very low. So incidence reports vary. They range from anywhere from 0.1 to 9% in the first 2 years after PE. There was a kind of a major study published in the New England Journal of Medicine that 2004 that very well defined, that was a very in-depth look at the incidence of this disease process. And that study quoted an incidence rate of about 4% after index PE. Interestingly, over half of patients who present with CTEPH will have no prior diagnosis of VTE or PE. We still don't totally understand the pathophysiology of this disease process, but essentially it's caused by persistent obstruction of the pulmonary arteries by organized thrombi, which leads to flow redistribution and ultimately remodeling of the pulmonary vascular bed. And then here's just the definition of CTEPH. Patients have to meet criteria for pulmonary arterial hypertension. But one point that I wanted to emphasize here is that patients need to be anticoagulated for at least 3 months before we start talking about is there any CTEPH or is there any CTED? So any evaluation for presence of CTEPH or CTED prior to the 3-month mark, prior to at least 3 months of appropriate anticoagulation is premature. So here's just the activation slide to kind of remind you guys of how to activate PERT consults. And then I just wanted to spend the last few minutes talking about our experience at WashU. So our program has been in place since January 2021 of last year. We are actively collecting data on each PERT activation. The database is being continually refined. We're continually refining the variables that we're collecting. Our total number of activations to date are 120. And at the time of the analysis, which I'm going to show you, this is again very preliminary analysis, there were 92 patients in our database. So the most activations were an average age of 60, and most of them were men. This is again in line with national averages. Most activations were either white or African American. Interestingly, almost a quarter of them had active COVID-19 at time of diagnosis or at time of activation. Most of our patients were in the intermediate high risk or massive PE category, which really enriches our cohort for sicker patients. You'll see here that most patients got their first dose of anticoagulant within an hour of their CT diagnosis of PE, which is really cool because this is in line with previously published data on how PERT impacts outcomes. So, this is just one study that I'm showing you here, but this was from the University of Rochester, published in 2019 in the Journal of Thrombolysis. But this group looked at outcomes pre and post PERT initiation and found that multiple outcomes were improved after PERT initiation, including time to heparin, time to admission, and time to diagnosis. We are still, one of the next steps in our research plan is to compare outcomes in patients who had similar PEs prior to PERT initiation to the patients who had a PERT activation. Now, that being said, while a lot of patients got their anticoagulation within the first 60 minutes, as you can see here, time from diagnosis to first therapeutic APTT varies widely. And Rachel kind of touched on this already, but this is a known challenge with ultrafractionated heparin administration in that it's sometimes very difficult to achieve therapeutic levels in a timely fashion. A few head-to-head trials have also, and this is again with previously published data, stating that sometimes it can take over 550 minutes to achieve therapeutic anticoagulation. And this is why sometimes in these PERT calls, you'll hear us recommending Lovenox instead of heparin, as long as patients don't have contraindications. Most of our patients are treated with anticoagulation alone. Only about 28% received catheter-based therapy. Our mean ICU length of stay was 6 days. Mean hospital length of stay was 10 days. We had a mortality rate of about 12%. Our 30-day mortality was 5%. This is again in line with national averages, and our 30-day readmission rates were 18%. We've had 23% follow-up after discharge from the hospital, and the rest are still pending. And here's just a poster, just some snapshots of a poster that were presented at the recent Barnes Patient Safety Symposium. One of our care physicians, Chris Palmer, surveyed the ER providers on satisfaction with PERT and found that most providers found PERT to be useful in PE management and that it expedites PE management. So, I wanted to thank, we wanted to thank a lot of people today. PERT truly is a multidisciplinary product, and we wouldn't be able to do it without the help and hard work of multiple people in various departments across the institution. We wanted to particularly highlight members of our PERT steering committee, Dr. Cavalli in IR, Dr. Sanfilippo in hematology, Dr. Palmer in ER, Dr. Oman in vascular surgery, Dr. Masood in CT surgery, and then Kevin, who's one of our MICU pharmacists. We also wanted to give a shout out to Dr. Chakanala for being a great mentor through this process, and the Division of Pulmonary and Critical Care, and then also to our research team and our nursing support who make PE clinic a possibility. So thank you. You guys have any questions?
Wonderful. Thank you both so much for your presentation, joining us here this morning. We don't have a ton of time here, so while I'm sharing my screen, the first couple questions came in kind of concern the use of low molecular weight heparin. It sounds like there tends to be a benefit towards its use. Is there any, does that cause a problem for any planned percutaneous intervention?
No, it doesn't. Patients can be fully therapeutically anticoagulated prior to getting these therapeutic interventions. So we've discussed that, with our vascular and IR colleagues, since they're obviously the ones that are doing these interventions, not Maanasi and myself. But no, it does not preclude them from getting a procedure.
One question I have, having started our PERT program during the time of COVID, and you noted that almost, 15 to 25% somewhere of our patients were COVID positive at diagnosis. And this is postulation, but is this going to be a new cohort? I mean, we have such a thrombophilic disease that's really kind of new. Do you think the data is going to be affected by that? Is it something we're going to have a separate category for these COVID-19 patients?
Yeah, I mean, that's a great question. In short, I can see that happening. I don't think we have clear evidence supporting that this is necessarily going to be a completely separate cohort from similar patients that had similar PEs. But I mean, that's a great question. I think we don't really know the answer to that yet.
Yeah, I'm curious. You mentioned one of the problems of the data early on is that so much is sort of one institution based. Are we have any partners in this process? Are you coordinating with any other PERT teams around?
Yeah, so that is a goal of ours. Currently, all of our data is single institution, but we are in the process of applying to the PERT consortium. And so hopefully as time goes on, as we develop data and, look into our own experience, hopefully we'll be able to partner with other institutions across the country.
Wonderful.
We have big plans currently, not quite there yet, but in the future.
Well, we look forward to that, and we'll have you back at some point to fill us in on what you'll learn as this thing progresses. So thank you again, both of you, for joining us. I'm sorry we're just about out of time, so we'll cut it short there, but thank you again for your expertise and for being here today.
All right, thank you guys for having us. Appreciate it.
Thank you, everyone.
Have a great one.